Aloha from Hawaii. I would first like to thank the committee to allow me to present to you our technology from a long distance. My name is Dr. Paul Ho, and I'm the founder of Hocor Cardiovascular Technologies. I'm also a practicing interventional cardiologist. Even though the Hocor device is at a very early stage of development, I believe our concept is well conceived. Our approach is based upon the use of a temporary aortic valve as part of an overall strategy and approach in percutaneous aortic valve replacement. The current approach for percutaneous aortic valve replacement is a direct stent over the diseased valve. I believe this is not likely to be the permanent strategy for aortic valve replacement. A good analogy would be the percutaneous treatment of calcified left main stenosis. Both the aortic valve and the left main are critical anatomic locations that tolerate few technical errors. Particular issues for concern are heavy calcification, vital adjacent structures, and hemodynamic support, which is available for PCI but not for percutaneous valve procedures. Therefore, if I may indulge on a wish list for percutaneous aortic valve replacement, these are some of the elements I would include in a comprehensive strategy: to have a way to modify or pre-treat the stenotic valve and the annulus such that placement of the prosthetic valve can be optimized in accuracy and in full circular expansion. This will ensure better long-term outcome of the valve and minimize complications. This may require tools to perform valvotomy or valvectomy by cutting into and removing all or parts of the diseased valve. Remodeling stents may help to conform the annulus to a circular structure prior to prosthetic valve placement. In order to do all of this, hemodynamic support will be essential because the native valve will not be functional for a brief period of time. Thus far, our company has focused our resources into developing a viable temporary aortic valve as a hemodynamic support system for this purpose. Key design features of the temporary aortic valve are easily deployed and retrievable via a catheter system, has to limit aortic regurgitation when the native valve has been removed, while it does not significantly hinder forward cardiac output, and it has to allow for adequate coronary perfusion. Also, the system has to allow for concomitant catheter work in the replacement of the diseased aortic valve via a central catheter. Most importantly, as we learn from aortic stenosis physiology, a fixed orifice can serve as a viable valve. Hence, the patients who are living with concomitant moderate range aortic stenosis and insufficiency. Based on various physiologic measurements, we conclude that a fixed orifice of between 25% and 60% of the cross-sectional area of the flow path should work. As such, a temporary aortic valve system consists of 3 inflatable balloons of equal size, should have a gap area with the ascending aorta of about 35%, assuming the balloons are fitted to have adequate apposition to the aortic wall. This falls well within the required balloon gap to aorta ratio of 25 to 60%. We built a prototype of a 3-balloon temporary aortic valve system in an in vitro flow model that we constructed using electrically timed ball valves. We simulated the pulsatile condition of the cardiovascular system and the condition of severe aortic regurgitation. In this chamber experiment, we tested a 3-balloon temporary valve system at the test site as indicated, using a standard strain gauge pressure transducer catheter system. In this in vitro non-physiologic flow simulation of induced severe aortic regurgitation, the presence of the balloon inflatable temporary aortic valve was able to increase distal aortic diastolic pressure, reduce widened pulse pressure, protect elevation in the left ventricular diastolic pressure, reduce aortic regurgitant volume. These are all desirable hemodynamic characteristics of a temporary aortic valve capable of providing hemodynamic support when the patient's native valve is non-functional during the modification and replacement process. Going back to a wish list, we think the valve removal tools are going to be the most challenging to develop. However, by using stent technologies, we believe that the valve or annulus modification can first be achieved. By placing low-profile stents in a concentric fashion, the annulus can be remodeled into a more desirable geometry prior to prosthetic valve implantation. These extra steps may also decrease on the structural burden of the prosthesis itself and thereby allowing it to be manufactured in a smaller, more compact device requiring smaller catheter system to deliver. Another way to visualize this is to assemble the valve prosthesis in piecemeal at the annulus by placing as many remodeling stents as needed to achieve a full expansion profile prior to installing the leaflet component. Each separate component will be less bulky and lower profile, requiring a small catheter to deliver. The following animation will demonstrate our conceptual approach to the next generation percutaneous aortic valve system. The procedure begins with a standard transfemoral access. The temporary aortic valve with the central catheter are inserted to the ascending aorta and deployed. Notice that the temporary valve limits the amount of aortic regurgitation while allowing for coronary perfusion. After balloon predilatation, the valve ablation or modification stents are placed to form a housing for the prosthetic valve. After successful placement of the prosthetic valve, the temporary valve catheter system is removed. We have a prototype made including the valve ablation stent or remodeling stent ready for animal testing. We intend to conduct our first animal model sometime this year. Please check out our website at www.hocorcardiovascular.com. Our manuscripts are in there for your review. Thank you for your attention.